Today we're going to be talking about, sorry, can we just start again, please? Just give us a few minutes.
Sorry about that.
Okay, this is.
Sorry, we are having some technical issues on Dr. Moidi's side. She'll be back in a second. Thank you for your patience.
Please check Dr. Moidi's microphone is muted.
Greetings to everyone participating in today's press conference on the rollout of COVID-19 vaccines to priority groups, specifically healthcare workers, older people, and adults with preconditions such as diabetes, hypertension, and chronic respiratory conditions. I'm very pleased, no, it's lower down. I'm sorry, we are continuing to have a technical problem here. Please excuse us. Right. It's too fast. I'm pleased to be joined for this conversation today by Mrs. Perpetual Ofori-Ampofo, the president of the Ghana Registered Nurses and Midwives Association, and by Mr. Ferdinand Sonyui, who is the chair of the Secretariat and Central Africa Regional Representative of Africa Non-Communicable Diseases Network. First, today marks 1 year since the WHO Director General, Dr. Tedros, described the spread of the COVID-19 as a global pandemic. However, the highest alarm WHO can ring under international law was already sounded much earlier. The Director General declared coronavirus a public health emergency of international concern on the 30th of January 2020. That declaration was a signal for all countries to urgently scale up response measures. In the coming days, Africa is expected to report more than 4 million COVID-19 cases and about 106,000 lives sadly lost. The continent has experienced a plateau over the past 3 weeks at around 70,000 new cases, and there is an upward trend in some countries such as Cameroon and Algeria. Sub-Saharan Africa and Algeria has now passed the milestone of more than 100,000 healthcare workers infected with COVID-19. That means 11 healthcare workers contracting COVID-19 every hour in this pandemic, accounting for 3.5% of all confirmed cases in the region. This proportion is higher in some countries such as Guinea-Bissau, Liberia, and Algeria, where over 10% of all confirmed cases among health workers. Slow it down. When health workers fall ill, our communities are affected from many causes. So we must do more to protect them, including on implementing the preventive measures to limit the spread of COVID-19. With COVID-19 vaccines now reaching the continent in limited numbers, healthcare workers must be at the front of the queue. We urge countries to follow WHO's guidance and vaccinate health workers first, as well as ensuring continuous access to personal protective equipment and providing funding for healthcare workers' investment plans to provide decent salaries, good working conditions, and sufficient staffing to cover the workload. This will help to reduce infections among frontline workers and relieve pressures on health systems. Older people and adults with comorbidities are also being prioritized for vaccination because they have a higher risk of severe illness and death when infected with COVID-19. Available data indicates, for example, that more than a third of COVID-19 deaths in African countries have been among people aged 65 years and above, whereas they constitute a much lower percentage of cases. This reminds us that access to treatment and action to prevent these mainly chronic non-communicable diseases needs much more investment and action in most countries in the African region. And we can't make strict separations between infectious and chronic diseases, and really just need to speed up progress towards universal health coverage. WHO's guidance is to prioritize the most affected population subgroups in line with the local epidemiology, and countries have defined and included these groups in their national deployment and vaccination plans. The COVAX shipments continue at a rapid pace, and as of yesterday, almost 14.8 million doses have been delivered to 22 African countries. This is great news. 19 African countries have now started vaccination campaigns, and through COVAX, more than 518,000 doses have been administered. We're also supporting countries to monitor the circulation of COVID-19 variants, with recent confirmation of the B1351, which was first identified in South Africa, in Cameroon, Malawi, Namibia, Eswatini, and the Democratic Republic of the Congo. This variant has now been reported in about 15 countries, while the variant first identified in the UK has been reported in 9 African countries. In closing, I'd like to give a shout out to healthcare workers for your leadership, for your dedication, and for your sacrifice for the sake of the health of everybody in your countries. I'd like to thank you all for having joined us and look forward to a very good conversation today.
Thank you, Dr. Moeti. Now let's turn to Mrs. Perpetua. Please tell us more about health worker infection.
Thank you very much. I bring you greetings from Ghana, and specifically the Ghana Registered Nurses and Midwives Association. Yes, COVID has not spared us as health workers. In Ghana, already as at 4th March 2021, we've had about 4,585 health workers who are infected. And as at October 2020 last year, we had about 14 deaths. And this is information from the Ghana Health Service. We ourselves as a union also collated our own data. And as of July 2020, we had about 840 of our comrades being infected. As at then, we had 3 deaths, and the rest of them fully recovered. As at January this year, we had 789 of our comrades who were infected, and the death toll has risen to 6. This is no different from the stories that we hear from our sister African sister unions and other African countries, and globally, health workers have not been spared. When we look at the figures, we know that over 100,000 have been infected, over 17,000 have died. This, of course, means that although we are health professionals, we know more about diseases and its impact and so on, we are not immune to the COVID-19 virus. And that is the more reason why we have called on all stakeholders, especially our national governments and so on, to prioritize the vaccination of health professionals. What I can share with you is that in Ghana, the vaccination rollout was initiated on the 2nd of March. And we had our President, His Excellency Nana Addo Dankwa Akufo-Addo, leading the way by getting vaccinated first, together with his spouse and the Vice President and his spouse. The program of the expanded program on immunization of the Ghana Health Service was to ensure that there are various phases of this immunization program that was planned from March to October. And the March to October simply means that not enough vaccines are available at a time to vaccinate everybody. The first batch of vaccines that were received was through the COVAX system. And at the moment, out of the over 140,000 health professionals or health workers in Ghana, we know per the figures from the Ghana Health Service that 60,398 have been vaccinated. The first phase of the vaccination covered 3 regions out of the 16 regions in Ghana, and that was the Greater Accra, Ashanti region, and the Central region. And that together meant that we were looking at a figure of 66,686 health workers. And out of this number, we know that 30,974 are nurses and midwives. So if we know that as at yesterday, 10th March, already 60,398 health workers have been vaccinated, then we want to believe that majority of our nurses and midwives have also received the vaccine. One thing to note is that this vaccination is not restricted only to the public sector. It also covers the private sector. So much focus is also on the community pharmacists, who are almost the first point of call for most Ghanaians. And in fact, not only in Ghana, but in most African countries. When somebody is having a headache or is coughing, the first point of call is a chemical shop or a pharmacy shop. They will not get up to go to the hospital. It is when they notice that their condition is getting worse, that is when they will move to the hospital and seek care. So for the vaccine program, the next phase, which is going to start on the 15th of March, is going to see to the immunization of health workers across the other 13 regions. And we are looking at a number of 76,078. And if you add a proportion of the private, then this will go up a little more. And we are hoping that everybody will get vaccinated. We've had to deal with issues of hesitancy on the part of some of our health workers and on the part of Ghanaians as a whole. And these had to do with the various conspiracy theories and myths running out there, that there are chips in these vaccines, it can affect your fertility, your potency as a man. It has been what is being used in other Western jurisdictions. It's not the same vaccines that are going to be given to Africans, and therefore it's going to have a negative impact on us. We have tried very hard to educate and sensitize the general public, and specifically for us as nurses and midwives. The union has taken it up, and we've had virtual engagements with members using a virtual seminar. And we have also developed flyers that we have sent out. And these are targeted to educate nurses and midwives to let them understand that, of course, vaccination has been with us for so many years. And indeed, if the white man wanted to kill us all, we would have all not grown to this age, we would have died earlier. And that the vaccines are safe, and therefore there's no need for us to harbor any fears. The leadership of the nursing and midwifery fraternity in Ghana, through the assistance of the Nursing and Midwifery Council, the registrar, we collaborated with one of our districts, and they launched their vaccination rollouts, and we were the first to get vaccinated. That is the nursing leadership. So myself and other comrades, including the registrar of the council, our chief at the Ministry of Health, and at the Ghana Health Service, we all got vaccinated. We took pictures, we shared on social media, and it was live on Facebook. And the hope was to assure our members that the vaccines are safe, and therefore they should all get vaccinated. And I'm sure it has contributed to the large number of our comrades who have stepped up to get vaccinated, and we are happy about that. Going forward, it's important that our various countries understand that we cannot sit back anymore when it comes to vaccine development and all that, and even some medications and logistics that we need in the health sector. It's about time we develop the infrastructure and the personnel to handle some of these things, so that there's so much money that is pumped into importation of vaccines year in and year out. Those monies can be pumped into local research and vaccine development and medicine development, so that we can have what we need at any point in time. That, of course, will also develop the trust of the people, and they can know that once it is from their own people, they can be safe in the use of it. We have realized that the COVAX system is making provisions, but that is not enough. We have also joined hands with the People's Vaccine Alliance to call on governments around the world to add their voice to the World Trade Organization to waive the patency rights on these vaccines, so that the technology can be made available to countries that have reputable pharmaceutical companies in order to develop these vaccines, so that everybody can have vaccines and get vaccinated. Because if we have to go the way we are going now, what it means is that there are certain countries that are going to have to wait for a year or a year and a half before some vaccines will even get to them. So we call on for more investment in health workers, especially nurses and midwives, if we really want to achieve universal health coverage by the year 2030. And we need to, in order to prepare ourselves for any such future pandemics. Thank you very much, and God bless you all.
Thank you, Mrs. Perpetua. Indeed, the vaccines are safe and effective. So let's turn to Mr. Ferdinand. Can you please tell us why we should prioritize people with chronic diseases for COVID-19 vaccination? Over to you, Mr. Ferdinand.
Thank you very much. I wish to, first of all, thank God for the opportunity to bring these remarks. And secondly, to thank you all for making yourselves available to listen. I wish to thank the WHO regional team for the chance to actually bring a perspective on non-communicable disease comorbidities, COVID-19 and the vaccines. I'll be doing so both as a young person, as a young advocate for health, and also as a civil society leader on NCDs in Africa. So we already know that 82% of the 16 million people who die prematurely from non-communicable diseases, of course, mainly heart disease, stroke, cancers, diabetes, and chronic lung disease, these occur in low and middle income countries, including Africa. Of course, and Africa is projected to experience 27% increase, that is 28 million more deaths annually by 2030. So the problem with chronic NCDs is not just that people are dying, but that they are dying too young from avoidable risks. We also know that the World Health Organization their strategic 5x5 matrix highlights the main categories of risk factors of NCDs and risk factors. And not surprisingly, they are the leading chronic pre-existing conditions responsible for millions of deaths we see today as a result of co-infection with COVID-19 virus. This includes, but not limited to, diabetes, hypertension, and you have other risk factors for these two, like obesity. Obesity, for example, is a significant risk factor for other NCDs and tops the list in risk for COVID-19 severity due to comorbidity. COVID-19 in people with comorbidities has increased the severity of the viral infection, leading to higher deaths than in a general population. We know that some of the measures that have been used, like partial lockdowns or restrictions, have limited access to prevention and treatment or control for people living with diabetes, with cardiovascular conditions, and obesity, asthma, and other NCDs. So people living with NCDs need attention because they have needs, they have challenges, they have priorities that must be listened to as we take meaningful action to combat COVID-19 in Africa. The Africa NCDs Network conducted an assessment late last year, which revealed that protection against the disease and knowledge of associated risks were the greatest needs expressed by African people living with NCDs during this time of the pandemic. And so looking at the African countries, some African countries like Cameroon, Ghana, South Africa, healthcare workers have come first in most of the plans that we have seen to roll out vaccines. We need to consider for whom the healthcare workers are caring. Yes, we know that they care for everyone, but people with chronic comorbidities die more in their hands than everyone else. It is vital to be specific on which NCDs and risk factors it is essential to focus on. And I think obesity, hypertension, diabetes are some key ones. Therefore, it is better, and we have encouraged people living with NCDs to follow prevention measures than risk getting the disease. And where vaccines are available, priority should be given to these people as the countries phase out their plans. We need to see that there is equity, especially looking at these groups of people who are vulnerable, like people with comorbidities. Thank you.
Thank you, Mr. Ferdinand. Now, on another note, we have our new Regional Emergency Director for Emergencies, Dr. Guy Salam. Dr. Salam will be telling us more about Ebola virus disease outbreak and other outbreaks in the region. And on hand, we have Dr. Nsenga Ngoi and Dr. Richard Mihigo. They will be there to answer your questions as well. Over to you, Dr. Salam, and welcome.
Thank you very much, Dr. Mary Stephen, and for having me. I just gonna highlight about 3 major emergencies that are currently going on in Africa. The first is about the Ebola outbreak in Guinea. The second, the Ebola outbreak in DR Congo. And the last is about the emergency that were made with the blast in Bata in Equatorial Guinea. In the Ebola outbreak in Guinea, so far we have 18 cases. And among those cases, there is 4 probable cases, which means that they died before we were able to test them. And there is also 1 positive case that were tested positive and died later. So the lethality is about 50%. I just left Guinea about a couple of days ago, and our teams are on the field working in collaboration and completely embedded within the government team. And they are doing several work, including the detection. And once the cases are detected, they work with the team in Guinea, the government team, to do the investigation in order to identify the contact and follow them for the 21 days necessary. And also the contact of contact, but because the contact and contact of contact should be vaccinated. So far, there is over 2,000 people that are, 2,600 people that are vaccinated. And we have been for 7 days without a new case, but we should be very careful because the detection is not yet optimal because of we have to put it in place, all the alert, and also for the death, whatever the cause of death, we should have an investigation and make sure that it is not related to Ebola. For the second outbreak, which is happening in North Kivu in DR Congo, we are in 12 cases. Yesterday only, we confirmed a case, but it is not a new case. It was a community death. And after investigation, it was classified as a probable case of Ebola. There also our team are in place. They were there for the last outbreak that happened in the same places in Butembo and surrounding areas. And we have vaccinated so far about the half of the number we did in Guinea. 1,300 people are vaccinated there. And our team are working in close collaboration with the team that are in place. As you may know, DR Congo have a lot of experience dealing with Ebola, and even at the decentralized level, people has some competencies that were developed through those experience. They responded firstly with WHO. So our intervention is less important there, but we are still working in very close collaboration, and it is the decentralized level that are actually intervening for the Ebola outbreak in DR Congo. And the last one is related to the blast that happened in Bata in Equatorial Guinea, where we have over 700 casualties, including 105 deaths. And currently there is 478 people that are hospitalized in the different hospitals. The country actually needs help. They have asked to the international community for help, and we are identifying the specific need that the country has. And one of the most specific needs that they need is human resources, and human resources that are surgeons, that are emergency people, and also nurses who are capable of taking care of those that are directly affected by the blast. But also, you know that the health system in Africa, wherever we have this surge of cases in hospital, even the other diseases are not taken care well. So it is a comprehensive help in terms of health that they are needing. WHO currently has all our people that are in place and available sent to Bata. There are 5, but also there is collaboration for the emergency medical team. And one emergency medical team is flying to be sent to Bata from Europe. There is also some experts that are being fly from Congo to be sent to Bata. We should remember that a similar thing happened in 2012 in Congo, and they have experience dealing with it. So thank you very much for inviting me, and I'm available for question. Over to you.
Thank you very much, Dr. Salam. Welcome once again to the regional office. So we have heard from all our panelists. It is now time for you journalists to ask your question. To do that, please go to the question and answer function on the Zoom platform and send us your question. And let us know if you would like to go live with your question as well. We need to know your name and the name of the media organization you represent. So the first question now is from CGTN Daniel. This is going to you, Dr. Richard. Can you briefly explain to us Africa's vaccine storage capacity and preparedness as vaccines arrive, and some of the challenges and mitigation measures? Over to you, Dr. Mihigo.
Thank you very much, Dr. Stephen, and thanks for the question. So with regards to the African vaccine storage capacity, it's important to mention here that during the last couple of months, preparing for the arrival of the vaccine, WHO, working with the partners, have really supported country to map out the capacity, the existing capacity of cold chain in all the countries. This capacity has been factoring in the national deployment and vaccination plans that different countries have developed in order to be ready to receive the vaccine. So overall, what we can say is that based on the national deployment and vaccination plan, the majority of the country have the capacity to accommodate the vaccine, particularly that the vaccine are coming in several tranches, not overwhelming the existing capacity. We have also 12 countries that requested an additional support through the Gavi mechanism to increase their capacity in terms of cold chain. So from all the countries, and we have heard from the regional director, 22 countries that have already received the COVAX vaccines, we have not we have not seen any issue with the vaccine storage. And we hope that this approach of having vaccine being delivered in several tranches is going to put less pressure on the system. Now, in terms of challenges, I think so far the countries that have started the vaccination, things are going on quite very smoothly. Indeed, there are some issues with notification of the data, the proper description of who should come first in terms of the priority groups. But in overall, I think the preliminary lesson that we are getting from country is that these vaccinations are going accordingly to the plans.
Thank you, Dr. Mihigo. So our next question is going to Dr. Moeti. Your question is from Maya of UN Brief from Switzerland. She's asking a similar question on vaccine preparedness and rollout of vaccination in Africa. And then the second question, I will pass it to Mrs. Perpetua. She wants to know how the Gavi vaccine arrival is seen by healthcare professionals and how the rollout of the vaccine is going on. Over to you first, Dr. Moeti, then Mrs. Perpetua.
Thank you very much, Mary. I didn't quite get the question. I understood it's going to be a question on vaccines.
Yes, so Mrs. Perpetua from Geneva is asking a question on the state of preparedness of vaccine rollout in Africa.
Yes, you know, African countries have been working for some months now, and WHO established a partnership group at the regional level to support the development of their national plans for delivering the vaccines, and also after they'd been drafted, to review these plans and to advise on how to improve them so that they are fit for purpose in terms of the process of delivering vaccines. So there's been a lot of work using global guidance developed by WHO to make sure that the key aspects of delivering these vaccines have been taken into account. The context of vaccine delivery based on the extensive experience in the region on carrying out vaccination campaigns, mainly for children, have been taken into account. So I'll ask Richard to provide the details in terms of how we assess now the state of readiness based on some criteria of most countries in the region. I would say that the countries in the region have done a very thorough job of their planning. There has been a lot of investment in reviewing the vaccination campaigns in terms of the campaign plans, in terms of what we know of what works and the challenges that are faced, admittedly, by the current situation. So Richard, if you can just provide the detail in terms of the assessment based on the tool that we developed in WHO.
Yeah, thank you, Dr. Moeti. Indeed, just to confirm what you've mentioned, I think we went through a very, very elaborated but thorough process, as explained, whereby a tool, a vaccine introduction readiness assessment tool, was developed by WHO, and the partners disseminated to all the countries. This is like 3 to 4 months ago, to try to anticipate some of the needs. So while countries were waiting for the vaccine to arrive, I think they did use that opportunity time to get very well prepared. And the tool was assessing 10 different components of the immunization system, from cold chain, as we have heard, communication, advocacy, monitoring of adverse events, the regulatory processes, and all of these different components were thoroughly assessed by the country, assessed on a regular basis, up to when they reach the stage of developing their national deployment vaccination plan. So I think to some extent, the long delay in vaccine arrival in Africa has been a positive thing to some extent, because country really take that opportunity to get well prepared. And what we are seeing today, and we heard from the colleague in Ghana, when the vaccine landed in the country, less than a few days after, the vaccination started, and there is a very well elaborated process. The provinces have been identified based on epidemiology. The high-risk group have been enumerated and identified. So clearly hitting the ground running exercise. And we are monitoring closely this process, and the gaps that are being identified here and there are being addressed. So quite happy to see what is going on, but also on alert to make sure that any specific issue is addressed on a timely manner.
Okay, thank you very much, Dr. Richard. Mrs. Perpetua, can you comment on the second part of the question? How do you see as health professionals the arrival of the vaccine and the rollout of the vaccine?
Thank you very much. In terms of the arrival of the vaccines, we are all very happy, or we were all very happy with its arrival, because for us as health professionals, we knew that if we have to nip COVID-19 in the bud, finally, what we need to do is get vaccinated. And it's not just about a few people getting vaccinated, but majority of the population being vaccinated. For on another wing, the fact that the COVAX system brought these drugs free to us, we also appreciated governments for the processes they put in as early as last year to get these vaccines. But there were still some skeptics who thought that, yes, these vaccines are free, but we also need to enhance the processes of procurement to get more vaccines to ensure that we reach the target of 20 million of the population. In terms of the vaccine rollout, how it's going on, yes, the FDA played its role, the Food and Drugs Authority played its role in ensuring the safety of the vaccines way before they arrived. And the cold chain system was boosted. Training went on for nurses who were going to participate in the vaccination, and volunteers who were also going to be taking part in the whole process. So after the training, as I said earlier, on the 2nd of March, the rollouts began, and that is the deployment. But what we also identified was that the date, in terms of the data capturing, the application that needed to be opened and information of the individual entered, there were some challenges. And it was due to internet availability and all those things. But gradually, the Ghana Health Service and the EPI department or units have been able to rectify some of these things. And the vaccination is going on smoothly. Thank you.
Thank you, Mrs. Perpetua. So the next question is from Laila from BBC. She would like to go live. Laila, are you there?
I am here. Thank you very much. My question is for Dr. Moeti. How concerned are you, Dr. Moeti, about claims that Tanzania's President Magufuli has contracted coronavirus and is seriously unwell? And if he is indeed suffering from COVID-19, what does that say about the strategy towards the disease that the government has been pursuing?
Yes, thank you very much. Well, as WHO, we have no information directly from the government regarding the health of President Magufuli. We have, like everybody else, seen information that's circulating in the press, in the social media. And first, I'd really like to say I wouldn't like to speculate in any way until we have some verifiable information as to what is going on. We note, of course, that Tanzania has recently recognized that COVID-19 is a health issue for the country. This followed the passing away of the vice president of Zanzibar and a senior official in the government as well, and has called for the people to adopt important prevention measures such as the wearing of masks. So we see that as a positive step for the welfare of the population of Tanzania and the neighboring countries. What I can say as WHO is that we can only encourage the government to support the population, to urge the population to use these measures, to take every possible action that they can to support people to catch up, in a sense, in terms of their own understanding and their actions and the facilities and the equipments and the supplies available, so that they can mount at the community level, individual level, and also at the public health level, the type of response that is needed. It's important that this includes the use of data to track the transmission of the virus in Tanzania. And we would very much welcome to start receiving from Tanzania data of the situation in the country so that we can provide support within the country, and most importantly, of course, internationally to the neighboring countries in Tanzania. Then finally, we would also like to strongly encourage the country to join the vaccination efforts of the whole world, including through the COVAX platform, so that they, like other governments, can protect their population from the spread of the virus. I think whatever is the case with President Magufuli, we can only wish him well if these stories are indeed true, and we very much reiterate our preparedness to support the government and the people of Tanzania.
Thank you, Dr. Moeti. The next question is from Naftali from Nairobi, Kenya. The first question goes to you, and Dr. Ngoi, you could complement, please. How serious is the threat of the third wave in Africa, and are there countries already experiencing it? And we have a complementary question. Do you see the continent managing to flatten the curve now that the immunization has commenced, and if so, when? Dr. Moeti, over to you, and Dr. Ngoi, you can complement.
Hello?
Hello, we can hear you. Over to you, Dr. Moeti.
Could you please repeat the question, Mary?
Yes, so Naftali is asking, how serious is the threat of the third wave in Africa? And are there countries that are already experiencing it? Then he's also asking, how is the continent currently managing to flatten the curve, given that the immunization has started?
Yes. I mean, I think that until such time as we have significant coverage with a vaccine, and that we see a return of the implementation of the prevention measures, which we have noted in the past few months have progressively been reduced, especially at the population level, there is always a risk that we can get an upsurge of cases. We have seen that when there are events that cause gatherings of people, for example, so of course the latest was the festive season where people gathered in many of the countries, and we did see an increase in cases. And we know that there are going to be in a number of African countries elections taking place, which are always a cause for concern, because the risk then of campaign events and people gathering is increasing the risk of an uptick in cases. We are seeing currently an increase in new cases in some countries like Benin, Togo, Botswana, Cote d'Ivoire, Ethiopia, Cameroon. So I think the risk is always there, and we always have to be emphasizing the importance of sustaining at the individual level the protective measures, the use of masks, the hand washing, and the keeping of a distance, which we have observed really is suffering from population fatigue and needs a resurgence of the of the efforts, improvement of communication, better understanding, and sustained intensification of the public health measures. So we think that this is extremely important at the same time as the vaccine is being deployed. Vaccines are being deployed in countries and are protecting at least the worst outcomes, which are serious illness and deaths, while the continent strives to acquire the level of vaccine supplies that will help us to reach population immunity.
Thank you very much, Mary, and thank you again for the questions. I will just compliment as you requested on what Dr. Moeti said. Yes, first of all, we have a very technical definition of our third wave, depending on the percentage from the last peak of the last wave. So taking into account that technical definition, we're not yet there. But as Dr. Moeti said, we clearly have countries that have now an upward trend, like countries like Cameroon. I mean, Dr. Moeti has mentioned some. That said, the risk, yes, the risk is again very, very real. First, let me clarify that the level of vaccination or the number of people who will be vaccinated, at least if this first round, is not significantly impact in terms of the transmission. We are going to protect people mortality. We are going to protect people from getting severe disease, yes. But in terms of significantly impacting the transmission, we need to still adhere to social measure as we have been trying to do it since the beginning of this pandemic. So the risk is there, and that's why, again, we need to emphasize with our communities to continue adhering to social measures. Thank you, Mary.
Okay, we've lost the sound.
Sorry, everyone. We're just having trouble with our moderator.
Yes, we're having problems with our moderator. I'm sorry about that. But since I know we're getting short on time, we can ask the following question, which is, sorry, just let me try and see what it is. The following question we have is actually on vaccines. So this, I guess, we have a question from Ben Television, Susan at Ben Television. And the question is, we'd like to know why there is no African country out of the 54 with an ability to produce any recognized vaccine for COVID-19. Does this not show that Africa is still relying on other countries for its development? And what can African scientists and the health industry do to bridge the gap? So perhaps, I don't know if Dr. Moeti or Dr. Richard Mihigo, if you would like to answer these questions. Thank you.
Yes, I mean, of course, I think to answer such a question, we have to look at the level of development, the status of economies, and the development of the research capability, both particularly in the private sector, because we know that these vaccines, of course, are being developed by a collaboration between scientists in the public sector and in the private sector in well-developed multinational pharmaceutical companies in most of the countries, or very much by major state entities in working also with scientists in the private sector in countries like China. So I mean, I think to be quite fair and frank, if we look at the capabilities of the economies, the scientific sectors, the African region is being acknowledged for many reasons, and we can go into the reasons, including the history of Africa, including the history of how Africa related with the more developed continents and countries over history. I don't want to go into stories like colonialism and slavery and what has happened in terms of global history and development, but simply to acknowledge that indeed there is need for African countries to invest more, and this has been acknowledged in Africa, and also to spend more on research. There are countries that do this. I think there are countries that have been able not necessarily to develop a vaccine from scratch, but certainly to participate in the discovery of vaccines. I think what we also have to acknowledge is that some of this is progressively and increasingly work that is being done collaboratively across countries, across both upper income, wealthy countries and lower income countries. And what we can encourage is the engagement of African scientists, encouraged and supported by their governments in this collaborative research, so that some of the research is carried out in Africa. There is some production capacity in some African countries, in certainly some countries like South Africa. It needs to be increased in some of the North African countries, which are already producing, manufacturing some vaccines that have been developed elsewhere. We have the example, of course, of the yellow fever vaccine that has been produced, developed and produced in Senegal for many years, and is the main supply of yellow fever vaccine in the world. So what I can say is that there is a realization of the need for more collaboration, certainly more investment in Africa, but I think we also need to take into account the state of development of the economies of African countries. Certainly, Africa has scientists that are as good as scientists anywhere else. I think what is needed is the partnerships, the working together, and the investment and resources, both then in participation in the discovery of vaccines, and also it's been very dramatically demonstrated in the manufacturing and production capacities of vaccines that may have been developed elsewhere.
Sorry, I think we're still having issues with our moderator, but I believe that Emile has a question and would like to ask it live. Over to Emile.
Yes, I'm here.
Yes, please ask your question. I think you have a question.
Thank you for giving me this opportunity. I address my questions to Dr. Moeti. The first one is a few weeks ago, the Minister of Public Health in Burundi said to wait until the end of the experimentation phase to order the vaccine, the COVID-19 vaccine. So the government of Burundi considers that the WHO and its partners are still testing vaccines. What do you think? And my second question is, Tanzania has about 60 million people, and Burundi has about 11 million people. What consequences can we expect in Tanzania and Burundi and in all the East African community region if these two countries continue to hesitate on the use of vaccines as well as on barrier gestures? Can we expect, for instance, collective immunity or chaos? Thank you.
Yes, I mean, I think the comment that vaccines are still being tested, first I'd like to precise it's not WHO that's testing vaccines. It is the scientific community working together, as I've just said in my response to the previous question, working together in partnership to develop And of course, test vaccines. Testing vaccines is a very important step on the way to developing effective and safe vaccines. It is absolutely necessary. We cannot have vaccines being developed in a lab and then being deployed on populations. These tests are being done under the strictest scientific standards that have been accepted internationally to make sure that in the process of testing, people's lives are not endangered and we come out with the best performing products that can be then safely used to protect people, the population. This has been done at an unprecedentedly rapid rate based on research and development that had been going on in the past, looking at these types of viruses. So I would say it is a very important part, testing of developing vaccines. It has been done properly and well, and there are processes ongoing to then look at the data and apply what we call in WHO an emergency use listing of the use of these vaccines. All these steps have been undertaken to the best international standards. After that, once the vaccines have been given this regulatory approval for emergency use by WHO and by the regulatory authorities of countries, then they are safe to use. And what I then will say to the next part of your question is that we are encouraging these countries, Burundi, Tanzania, other countries that have yet to come on board, to do so and are committing to support them. Some have questions remaining about some of the requirements for them to be able to have access to the vaccines. And it's been said by many people before in our urging the international community to collaborate and ensuring that there is equitable access to vaccines. As long as there are pockets of populations that are not vaccinated, that puts at risk everyone. So it applies within the neighborhood in East Africa that you cited, that as long as there are countries that are remaining behind with their population not vaccinated as others are moving ahead, that's going to continue to constitute a risk. Particularly, I'd like to add, because the reality is that in African countries, although we would wish to have that ambition, it will not be possible to very rapidly acquire the vaccine supplies and within some months or even within this year, be able to reach the level of coverage of populations that will give population immunity. So this only then remains for us to continue to encourage and to urge these countries to know that their neighbors have used the information that's available internationally of how these vaccines were developed. And to add that there are many, many vaccine candidates in many countries that are being developed. There is a very meticulous process of ensuring that the highest standards are being applied before these vaccines are being licensed or listed for emergency use in countries. So I'd urge the countries to trust WHO, to trust the scientists and the international community, and to act as first good leaders and the responsibility for their own populations and also responsibility for the neighborhood. I think we have something called the International Health Regulations, which urges all countries to work hard to prevent the international spread of disease. And then this is something that we would encourage them to also take into account as they are signatories of the International Health Regulations.
Thank you very much, Dr. Moeti. Again, apologies, everyone. We continue to have issues with our internet. But I think we will now start wrapping up this press conference. I'd like to go to our speakers for their final remarks. Mrs. Perpetual, over to you.
Thank you very much. I want to first of all express my appreciation to the WHO for this opportunity to be a panelist in this virtual press conference. Indeed, the issue of COVID-19 and its impact on population is one that is going down in history as what we will all talk about in the years to come. But for the fact that we don't know what the future holds, it's important that we all continue to work together, to collaborate, to partner, and to see to it that what needs to be done is done in terms of vaccine development, vaccine deployment, and all that, so that we can get to everyone to be vaccinated, to be protected. Going into the future, the fragile health systems that we have need to be developed. and the allocation of health budgets should be enhanced. Per the Abuja Declaration 20 years ago, governments committed to apply 15% of the national budget to health. And most of these countries are doing way below the 15%. But we can do better, 15% or more, so that we can adequately develop the health sector in terms of infectious disease and also building the capacity in terms of medicine and infrastructure for other communicable and non-communicable diseases. So we hope and pray that even as vaccination goes on, health workers everywhere will be prioritized so that we can be adequately protected to give the care that we are trained to give. Thank you very much.
Thank you very much, Mrs. Perpetual. We echo and hope that also healthcare workers will get vaccinated soon. Over to Mr. Ferdinand.
Thank you very much. I just wish to really say that, you know, non-communicable diseases are responsible for more than 70% of the disease burden. But yet they are not just underfunded, but they are also almost always, and I say this, almost always neglected in considerations when it comes to making things work for those conditions. As an advocate for NCD prevention and control, it's important for me to state that during this COVID-19 pandemic, the people living with NCDs have cried for protection. The services for these people living with non-communicable disease have been disrupted. And there is need in recovery to make sure that we don't just listen, but that we act as far as NCD prevention and control is concerned. And that action means that we need to prioritize people living with chronic NCDs as far as vaccines are concerned, so that they can be protected. And this is one of the things that we know we have listened and heard. They need to be protected from these, from the severity that is as a result of COVID-19. So I think those are some of the key messages. We need to keep supporting these people and other priority groups. Thank you for the opportunity to be on this panel, and I just thank you for the opportunity to be here. Thank you.
Thank you. Now over to Dr. Moeti.
Yes, thank you. So first, I'd really like to thank my fellow panelists for having joined us, Mrs. Ofori-Ampofo and Mr. Sonyu, and for having exchanged your rich experience and your point of view on these very important two themes with us and with our colleagues, the journalists. And to conclude and to make the link again, you know, I really think nothing can say it better than universal health coverage, which increasingly sounds like a slogan, but which is the framework within which we can work on all of this. We can deal with, of course, the very precious resource, human resources for health, which is health workers, which is at the core of our ability to achieve universal health coverage and manage our healthcare workers, invest in them, invest in our systems so that they are present everywhere, able to provide services to detect outbreaks, including those that might lead to a pandemic, and to work to provide the public health interventions that are needed to contain outbreaks and to protect them, as is being done now by putting them at the top of the queue as far as access to vaccines is concerned. And then again, to make the link between chronic non-communicable diseases and other health conditions. And I think we, in order to be efficient, and it was said by our colleague, Mrs. Ofori-Ampofo, that financing for health is a challenge in the African region. So we must find ways to make links between what is invested in infectious diseases and the benefit for non-communicable diseases and the types of similar interventions as we develop our healthcare systems and as we inform people, educate people, help them to be health literate and to take care of themselves, as we make legislation and regulations that reduce some of the risk factors that drive some of these diseases, both in terms of communicable and non-communicable diseases. So I think the pandemic is teaching us that this is all interconnected, and our strategies, our actions, including at the household level, need to take that into account. And finally, just to say that we rejoice that we are able to start this vaccination, and we see that the opportunity is there to expand this work. But in the meantime, we must continue with the public health protective interventions at the household level by individuals and also in the public health system. So while we are working on the vaccines, we must still work on the testing, contact tracing, isolation, until we reach such a stage that the risk of the virus being transmitted is very much reduced. So thank you all for having joined us this week.
Thank you very much, Dr. Moeti, and all our panelists. Again, and thanks to the journalists who have joined us. Again, apologies for our internet issues, which unfortunately continue. Thanks. Have a good week.
Thank you.
Thank you.
That was a nightmare. Oh, no, that was a nightmare.
A little bit painful.
Oh.
I'm sure you've seen there's been a lot of buzz around it. So just some house rules quickly. Remember that you must indicate if you'd like to ask a question live. We have facilities for doing so. So please just indicate and use the Q&A section to pose your question. Please introduce yourself and your organization, and also let us know to whom you'd like to pose your question. Front row, if you could please translate for me in French, including the fact that we are simulcasting in both English and French. So please go to the globe icon at the bottom of your Zoom app and select your preference now.
Bonjour à tous et merci de vous être connectés pour ce briefing. Si vous souhaitez entendre la conférence en français, vous pouvez aller dans l'option d'interprétation qui est disponible sur Zoom, le globe, et cliquer sur français. Pour poser vos questions, merci d'utiliser la fonction Q&A ou questions et réponses de Zoom, en précisant votre nom et votre média, et également si vous souhaitez que nous prenions votre question en live. Merci à tous et bon briefing.
All right, thank you very much, Francois. So let me please introduce my panel this afternoon. Joining us from Brazzaville, the Republic of Congo, is Dr. Matshidiso Moeti, who, as you know, is the WHO Regional Director for Africa. She is joined by WHO Africa immunization expert, Dr. Richard Mihigo. From Johannesburg, South Africa, is Professor Helen Rees. She is Executive Director, Wits Reproductive Health and HIV Institute at the University of Witwatersrand. She's also chairperson of the African Regional Immunization Technical Advisory Group and chairperson of the South African Health Products Regulatory Authority. Also joining us is Professor Pontiano Kalibu, who's Director, Uganda Virus Research Institute and MRC UVRI and London School of Hygiene and Tropical Medicine, Uganda Research Unit. He obviously joins us from Kampala, Uganda. Welcome, and welcome to you as well, Professor Frederick Were, Perinatal and Neonatal Medicine, University of Nairobi, and Chief Research Scientist at Kenya Pediatric Research Consortium. He is in Nairobi. So let's start with the discussion. I'm going to turn to you, Dr. Moeti. If you could just tell us what the latest news is on COVID-19 vaccines and where Africa stands. Dr. Moeti, if you could please unmute.
Ask them to unmute. Okay, this is stupid.
We can hear you, Dr. Moeti. We can hear you.
You can hear me now? Okay.
Yes.
Good morning, good afternoon. Thanks very much, Tsepiso. Bonjour à tout le monde. And thank you all for having joined this press conference on COVID-19 vaccine readiness in the African region. I'm really pleased to be joined by some friends and colleagues. First, Professor Helen Rees, then Professor Pontiano Kalibu, and Professor Frederick Were. Welcome to you all, and thank you so much for having joined this conversation.
I do apologize for interrupting you. I just don't have a visual of you at the moment. I don't know if anybody else does. If we could just start the video, please.
Okay, I will pause a moment while we sort out this technical.
Yes,
can you hear me?
We can absolutely hear you, but unfortunately we can't see you. We will, if you'll allow me then to just move on to the next panelist while we sort that out. And I do believe we also don't have Professor Helen Rees with us for now, but we will get to her when she also joins us. So we're doing this rather higgledy-piggledy. Normally this is not the process that we do, because we hand over to the WHO regional director to just give us an overview of where we are. But let me come to you, Professor Pontiano Kalibu. Perhaps you could just talk to us about
Dr. Mweti.
Uganda.
Dr. Mweti.
There we go. All right, thank you. Dr. Mweti, apologies for that. Let's go ahead.
Activity issues, which sometimes happens where we are. So again, I'd like to say good morning, good afternoon, bonjour, and thank you all for having joined us today to talk about COVID-19 vaccine readiness in the African region, and to say a warm hello and welcome to colleagues and friends. I hope Helen will be joining us soon, Professor Helen Rees, but hello to Professor Pontiano Kalibu and Professor Frederick Were. Thank you so much for having taken the time to join this conversation today.
I'm here with you.
With 3 COVID-19 vaccine candidates demonstrating high levels of efficacy, many countries are keen and determined to get the vaccine on time. We do know that African countries are concerned and hoping that pre-ordering of millions of doses of vaccine by wealthy countries will not disadvantage their accessing supplies. I think this is very much the issue of today that's being discussed all over, especially in the region. Vaccination in combination with tried and tested public health measures will help end this pandemic. And as the COVID-19 vaccine is rolled out in phases, it'll turn into the biggest vaccination drive in the history of the continent and indeed the history of the world. At WHO, we're working with countries and partners to prepare for this unprecedented initiative. And 40 African countries, we have 47 countries in our region, have shared data with us assessing their readiness. So we sent them a readiness assessment tool, and I'm really glad that most countries have relatively quickly started to use it and provide us with the data. And what we see is that so far, the average readiness score is 33%, which is well below the desired benchmark of 80%. So we are doubling down on planning and preparation because this will make or break this unprecedented endeavor. In our region, we're assisting countries to develop their COVID-19 vaccine introduction plans, including by leveraging our vast network of polio and immunization and other public health staff on the ground under the leadership of our WHO representatives. So we have physical presence in all the countries in the region, and these teams have started to work hard on this. And I had the opportunity to brief all the ministers of health when we had a meeting with them 2 days ago. We know that communities have played an incredibly important and central role in stopping the spread of COVID-19, and they'll be central in the rollout of the vaccines. It is critical that authorities reach out to communities, listen to their concerns, and give people a voice in the process of developing and implementing the delivery strategies. it's also critical to fight against false anti-vaccine information. So here I'd like to ask for your help, dear colleagues, journalists, to make sure that in the coming months, the vaccine narrative continuously emphasizes equity. We've promised Africa's ministers of health to do all that we can to ensure countries in the region are not left behind in the race to deploy vaccines, and I ask for your support on this. There are also key logistical and financing gaps where international solidarity will be imperative. The promise of vaccines comes as Africa reports more than 2.1 million COVID-19 cases and 50,000 people have sadly lost their lives. We've had a plateauing of the number of new cases per day, but we are starting to see an uptick, and that gives us a lot of concern. Countries in the Northern Hemisphere, including in North Africa, are reporting high daily cases as they move into their colder months. This is similar to what we saw at the beginning of the pandemic. And as I was saying, here in the region, the curve is once again trending upwards a little bit as we head into the holiday season when people will travel. It's vital, therefore, that we continue practicing the preventive measures and that scaled up proactive public health capacities are in place to flatten the rise in cases. At WHO, we're working with UN agencies and other partners at country level to provide support in this endeavor, including around the response to the pandemic and providing essential services for health, because we don't want this to suffer as we focus on COVID-19. So I look very much forward to our conversation today, and I thank you all for having joined us.
Thank you so much, Dr. Moeti. And just a reminder once again to my colleagues that should you wish to pose a question live, just indicate so and we'll be able to assist you. So now let's hear from Professor Helen Rees. It would be lovely to get your insights specifically with regards to various COVID-19 vaccines that are showing promise. Professor Rees, welcome.
Thank you very much. And thank you very much for the introduction and for inviting me to be on this discussion. And I think it's really excellent to have discussions like this because the data is changing so quickly. So I was asked to talk about the pros and cons of different vaccines and what would make decisions be appropriate for us in the African region and for other parts of the world, considerations that they might be looking at. First of all, I think it's clear that the first thing that you need to have is an effective vaccine and a safe vaccine. And the good news is that early results from 3 vaccines now, the Pfizer vaccine, Moderna, and the AstraZeneca vaccine have all started to show really exciting and promising results. So that's good. And they all look like they're safe at this interim stage of analysis. All of these vaccines, once we see that level of effectiveness and safety, even though the trials will continue, are likely to apply for an emergency use, either through the FDA or the European Union, and then later on with respective national regulatory authorities. So what are the things that we would be thinking about as we consider the characteristics of these vaccines? Well, the first thing is very practical things like how many doses do we have to give? Is it 1 dose or 2 doses, and how far apart? And can a program sustain that? The thing that's actually gained a lot of attention and discussion recently has been what's called the ultra cold chain with the RNA vaccines, in particular the Pfizer vaccine that requires at the moment a -70. Pfizer are working on this to try and change that parameter of the vaccine and make it more program friendly, but that's what it is at the moment. And clearly for the African region to have a widespread rollout of something that requires that kind of capacity in the cold chain would be very challenging indeed. The third thing would be, what do we know about the effectiveness? We heard that for the AstraZeneca, the overall effectiveness was about 62%. But when they looked at a lower dose, lower first dose, and a boost, which was the full dose, they went up to 90%. But effectiveness efficacy from these trials rather is going to be very important. And as I said, safety. But we're also going to be looking at things like, do these particular vaccines work in particular groups? So given that the elderly, older people over 60, go up quite quickly in terms of risk, how effective is any one vaccine versus another in that age group? Because we do know that vaccine efficacy wanes with many vaccines as people get older. Now, that, on the other hand, might be a bigger consideration if you have a population with a large number of older people. And it might be less of a consideration, for example, in the African region, where we might say, actually, even if we've got lower efficacy in that age group, what we really want to do is target this group, which is somewhat different because our demography is different and our economic profile is different. All of these things will need to be weighed up. And then clearly, for our region, the issue of cost. So the newer vaccines, these mRNA vaccines, are much more expensive when we compare it to, say, the AstraZeneca vaccine, which is a more established type of vaccine platform. So cost is going to come in, notwithstanding the excellent work that's happening through the COVAX facility. But for countries that are doing bilateral negotiations, cost will be a factor, and even through the COVAX facility, cost will be a factor. But the encouraging statements that many companies are making about public health pricing is really great news. I'll just briefly mention vaccine hesitancy, which is something that is also gaining a lot of attention because a lot of misinformation is going out there. For the African region, we had a problem right at the beginning of the pandemic, where unfortunately 2 French doctors had a conversation that went viral, where they appeared to be saying it's a good idea to come to Africa to do clinical trial research because we will have a big problem. And that was perceived as perhaps the African region being looked at as guinea pigs. And that created a very negative dialogue in our region, in some countries in particular. So since then, we've had, I think many of you will have seen a lot of misinformation coming out in social media, etc. And the mainstream media really trying their best to give accurate and complete information. And that's what we have to keep doing. There have been a number of surveys now. One was published in Nature Medicine, which showed overall about just over 2/3 of people said that they would feel that they would like to have a vaccine or they would be willing to have a vaccine. But some people still being very reluctant to the extent of refusing it. That's about 1/3, and that was global. Very different figures from different countries. And men being less willing than women overall in that survey, and people who had more education being more willing than those who had access to lower education levels. So all of these things will have to be taken into account. And as we think about vaccine hesitancy, and that's why this dialogue is really, really important, we should really think about, what is the message that what would communities want to hear from us? The first thing I would say is we're going to have to break those communities down into different types. So we're going to have to think about who are our communities, who are our populations? Do we have the same message for older people who from that survey appear more willing to have a vaccine, and the same message for younger people who we know from their sort of behavior all around the world, it's quite easy for them to feel that they're going to be minimally exposed and minimally sick. So do they want a vaccine? What message do we give for these different populations? In many countries in our region, for example, we haven't ever targeted older people before. How do we target them and say, this is something new, we now want you to be immunized? What is the message there? And the important thing in that messaging will be to be very transparent about what we know about the vaccines, what we know about safety and efficacy, when the vaccine needs to be had, and also why we want people to be vaccinated and why it's so important to build up the population protection. But early on, one other message that will be complex to get out when we have limited amounts of vaccines, this will be a worldwide issue, is why are we targeting some groups and not targeting other groups? That explanation will also be very important. I'll stop there. Thank you.
Thank you very much, Professor Rees. Very interesting to hear that perspective, and I'm sure there'll be quite a few questions coming out of that. So let's move on now to Professor Pontiano. Kalibu. Now, you're going to talk about the COVID vaccine clinical trials in Africa, the vaccine pipeline, and also, if you can, just tell us about how Kenya is preparing to roll out the COVID-19 vaccine.
Thank you very much. I think the last one for Kenya will be for my colleague Frederick, who will talk about Kenya. But as far as vaccines in Africa is concerned, first of all, the vaccine pipeline. I think COVID allowed the vaccine research community to roll out a number of vaccine candidates, but using platforms which had been used in other infections, but good enough, some have really advanced into human clinical trials. I think the pipeline moves from inactivated vaccines, live attenuated vaccines, non-replicating vectors, such as the chimp adeno, which we'll talk about, replicating viral vectors, using them as vectors to carry the vaccine components. The RNA vaccines, very exciting, which two of them have come now to be efficacious, messenger RNA, DNA vaccines, protein subunit vaccines, virus-like particles. So we have a number of pipeline of vaccines, and some of them have moved into human trials. As we speak now, I think approximately 35 vaccine candidates have gone into human trials. And I'm happy to say that Africa is making a contribution, especially South Africa. South Africa, as you know, has had the highest number of COVID infections, but also now has the highest number of trials that are being conducted in the phase 3. The earlier one using the AstraZeneca, the chimp adeno, which the Oxford group, which has shown some efficacy, and I hope the trials will continue in spite of this, so that we can have the full trial completed to really know how good this vaccine is. South Africa is also conducting another phase 3 trial using a recombinant approach, which is developed by Novavax company, and it's in the phase 3. And the last one in the South Africa is using the adeno 26 with Johnson & Johnson. We have had a lot of experience with the adeno 26 in Ebola vaccine trials. We are using it here in Uganda for Ebola. So some of these vectors, like the chimp adeno of Oxford and the ad 26 are not new vectors. They have been used. So that gives us some, I think, confidence that these are not completely new vectors that are being used. So 3 trials in South Africa. Kenya recently started also to be part of the Oxford vaccine trial using the chimp adeno. That's the AstraZeneca, again as a phase 3, and I hope those trials will continue. For us here in Uganda, we haven't started our trial, but we want to go into a phase 1 trial using a self-amplifying RNA vaccine. And the plans are ongoing. We have delayed just because we want to really get the right doses that we need to use. But otherwise, we have had some preparatory studies going out to the communities to understand what knowledge do they have about vaccines, how acceptable vaccines are, especially in health, among health workers. And we're very excited to see that there was a lot of interest in participation in vaccine trials. Of course, now we know that with the results that have come out, 3 vaccines that have shown quite a good efficacy in terms of protection, how this is going to affect the vaccine pipeline and trials that are being planned. We, WHO and others, Africa CDC, we have been working together on the solidarity trials, adaptive trials, where new vaccine constructs will be introduced and test their efficacy. How the new results are going to affect the design of the solidarity studies needs to be discussed, and will be interesting how this will affect. Do we go ahead with all the trials we had planned? The trials will need to be bigger because now we have vaccines that are working. If they're introduced into the vaccine design, definitely that is going to affect the way we conduct additional trials. My feeling is that although we have these vaccines that are effective, appear to be effective, and as Dr. Moeta has mentioned, the plans to roll them out, this should not stop the research and development of newer vaccines. We don't know yet how long the immunity will last for these vaccines that are coming on. So there's a lot that we need to understand. Some of them, as you have heard, they need very cold storage, -70, -80. So newer products could come on that could be effective and easier to distribute. So I think the research and the trials should at the same time go ahead, although they will be more complicated and they will need larger trials because we already have a few vaccines that are proving to be effective. So I can say Africa is participating and will continue to participate in these studies. Of course, we'll be adaptive to the new results that we get as they come along. I think we will not be surprised if we get additional exciting results that come on, and we'll continue to discuss how we design these studies. But otherwise, Africa is beginning to contribute, and interestingly, and which is good enough, there is acceptance of vaccine studies and vaccine trials. There's challenges ahead, but I think we are making a contribution. Thank you.
Thank you so much, Professor Kalibu, much appreciated. I'm going to now to speak a little bit more specifically about Kenya to Professor Frederick Were. If I could just ask you, if you can, Professor Were, to just take 5 minutes so that at 1:30 exactly, I mean 12:30 my time, 11:30, I think Brazzaville time, we can start taking questions.
Thank you very much, and good morning, Helen. I haven't seen you for a while, except here. In addition to the nice introductory remarks made, I also am the chair of the NITAG of Kenya. I could say a word or two about the preparedness. I'm not certain about what was sent to WHO in terms of our percentage preparedness, whether it's on that, whichever side of 30, but we are having a full weekend meeting beginning tomorrow as a NITAG to hear that from the ministry. What I can say is that at political level, at immunization health systems level, at the department in the ministry level, I think there's been a lot of movement for us preparedness. The conversation that has been available at really our levels, I think, despite not knowing the exact percentages, that has remained on our lips. We were in advanced stages of expanding our primary schedule to include 2 new antigens, which is, I think, the second polio injectable and probably conjugate typhoid. Those are some of the maneuvers we shall be speaking about, so what we can stagger and go on, what must be done. Having said that, we generally have a fairly resilient immunization health system in cold chain, but it's not resilient in terms of those demanding -70. That's one end that we would be in a bit of trouble here if we have to implement. Another issue that is of importance in Kenya, probably a few other African countries, is that when we will be defining the categories of risk and those we must react to first, in this country, in the last 5 or so years, the population of over 60, which is what we regard here as the elderly high risk, it might be defined differently elsewhere, has actually now surpassed that cohort. So we have more than 1.5 million out of a total population of 44, that's now over 60. So even if we narrow down to the most at risk, the health worker population may not be as large, but if you look at all the frontline people who work in health facilities, it's also significant. So we will be maneuvering ourselves in the next couple of days how to define the sequence in which we should do the vaccination as the actual products come in. And importantly, we will have to be careful about which one we choose if they're both available, because my view is that one that requires -70 will not go far enough into the labyrinth of the health system regarding immunization. But politically, I think I can assure people that the innuendo I'm hearing is that people are ready. Administratively in the ministry, we are prepared. The systems, the advisories will be coming out by the end of this weekend. And at least we qualify in Kenya and most other countries to benefit from the Gavi support, which brings, I think, the cost down probably $2, but those slightly less than that. So we haven't got where we want yet, but we have given ourselves maybe the next couple of weeks to make sure that we define our capacity to absorb and deploy the vaccine when they become available. I think I can leave it there for the moment and hear other questions. I don't have an exact answer to what percentage of population, but if we repeat this conversation on Monday, Tuesday, I'll have had full feedback from the immunization program, which is happening tomorrow and Saturday. But I've been aware that we have been active in preparing. The moment we started hearing the vaccines are in the advanced stages, conversations have gone on administratively. Now they're coming to the advisory level beginning this weekend. Thank you.
Thank you so much, Professor Were. So it's time now for the Q&A section of this discussion. A reminder to my colleagues once again that if you'd like to ask a question live, you're more than welcome to do so. And please indicate to whom you're posing the question. Also introduce yourself. Don't forget to do that, including your organization. So we're also going to be able to answer questions in both English and French. So if you'd like to ask a question live in French, we do have interpreters, but also we will be able to have it interpreted if you're not asking it live. So let's go to the first question. I'm going to make sure that Kate Bartlett is available. She's from German Press Association. Kate, are you able to ask your question now?
Yes, can you hear me?
Yes, we can. Please go ahead.
Okay, hi, thanks very much. I have a question, I guess, for Dr. Moeti, but anybody else who has an answer. Firstly, when do you expect the first African countries to get a vaccine through the COVAX platform? And second, given the issues of cold storage for the 3 vaccines that have become available, how do you envision the vaccination campaigns working in some African countries? Thank you.
Thank you, Kate. Dr. Moeti?
Yes, thank you for that question. I'll start to answer, and my colleague Richard Mihigo could perhaps supplement. Through the COVAX, we are aiming to have an initial supply of vaccines to cover 3% of the population, so the highest priority group to be covered. And we're expecting this will be healthcare workers and also, as has already been said, the most vulnerable group, which is the elderly. And the expectation or the plans of the platform are that some of these vaccines should start to become available late in the first quarter of next year. So progressively, we are expecting by the end of next year to have been able to provide vaccine to cover 20% of the population, and then think that what is being done by other partners, especially the Africa CDC, will cover some of the rest, but we'll still be working with countries in the COVAX platform on this. And then the question of the cold chain, I think my colleagues have already, in their introductory remarks, addressed partly this, that the Pfizer vaccine, which requires temperatures of minus 70 degrees, will indeed be a huge challenge for most of our countries to be able to provide the conditions to distribute countrywide. We think that the other vaccine, which is going to need minus 20 degrees, might be more feasible, but certainly the AstraZeneca vaccine, which, although it has a lower efficacy, but it's certainly sufficient to provide population immunity at 70%, is going to be stable at the kind of conditions where African countries do have the capacity to distribute it, so it doesn't need the ultra cold chain. So that's the situation as far as that is concerned. If you permit, Tsepiso, I'll see if Richard has any addition to say to this.
Yes, please. Dr. Mihigo?
Yeah, thank you very much, Dr. Moeti. I think we've addressed most of the issue raised. Just to add that as part of the preparatory activities that are currently being conducted, as you mentioned in your introductory remarks, I think we are assessing a certain number of preparedness parameters in different countries, and one of them is the cold chain and logistics system in the different countries. So though, as it was mentioned, the overall weighted preparedness is around 53%, but we have seen that in different pillars in the preparation that we are following in the different countries. So countries are at a very different stage in those areas, and in particular with regard to cold chain, with the pre-existing system that are already handling the routine vaccination. So there will probably be a need to adjust a bit some of these, and we are currently supporting member states to make sure that the gaps are identified, and then resources be mobilized to as much as possible to fill those gaps before the deployment of the vaccine can start. So thank you.
Okay, thank you, Dr. Mihigo. So let me move on to the next question, and it's from Falilia from France Info Afrique. So I'm going to ask Professor Rees and Professor Kalibo to attend to this one. So it's two questions. Does a vaccine have to be tested in Africa to be efficient for Africans? And if so, is one from AstraZeneca that's been tested in South Africa? What are the results thereof? Perhaps Professor Rees, you can answer that one as well. And the other question is about the storage modalities of the vaccine. AstraZeneca seems to match that of Africa's environment, says Valilia. Can you please remind us, what are those modalities? And if this vaccine is really the only one for Africa, are there other vaccines that can be better suited with the continent's constraints? So Professor Rees, we'll start with you, and then Professor Kalibu, you can answer thereafter.
Thank you very much. Very good questions. So one of the things that we as African scientists and clinicians and policymakers have been arguing very strongly is that we really should be doing some of this vaccine research in the African region. The very good news about, for example, the Moderna vaccine, excellent news, but no trial sites in the African region. And in discussion with the company and in a WHO discussion, we were able to say, what are your plans? Do you have plans for coming into different populations? Clearly, many of these companies which have done big trials, for example, in the US, have had diverse populations integrated into them, but that isn't the same as looking at African populations who live in our settings, because there are many other things that can influence the way that a vaccine works. For example, coexisting other conditions like malaria, other conditions that affect the immune system that might be more common in our settings. So to answer you, the preference certainly would be to have at least some clinical trial sites in the African region. And for products that haven't been tested in that way, I think we would want to encourage the companies to think very rapidly about how they can rapidly do a study. And it wouldn't be the same doing the whole efficacy study again, but it would certainly be a study that would look at aspects of safety and the immunogenicity. Well, how does the immune response work? So certainly that's one issue. And then in terms of the AstraZeneca, the results that we saw did not include the South African results. About 2,000 participants were enrolled in South Africa. They didn't include it. Interestingly, when we went into the field in South Africa, it was as we were reaching our first wave. And in fact, we had very few what are called endpoints. So very few people actually developed COVID across both arms of the study. So they didn't include those results, but those results will be able to give us safety data and immunogenicity data.
Okay, thank you. So Professor Kalibu?
I think the issue of Africa has been well answered by Helen, but also to note that studying of these vaccines continues. Even as they're being rolled out, initially there will be a lot of information that will be collected, especially on safety, but also in the immune responses. So this information will continue. So it is desirable to do, and it will be nice to do some studies in Africa, but that's not a condition to really introduce vaccines in Africa. They can be tested elsewhere. But as Helen has mentioned, it will be desirable and nice to know how these vaccines fare in the African population. Sometimes vaccines behave differently. A very good example is BCG, which behaves differently in different populations. But this will continue to be studied. Storage is an important thing. One of the vaccines is stored at -70, another one -20, another one 2 to 4 degrees. But again, still, they will continue studying, is it possible to lower the temperature for the Moderna vaccine to lower the Pfizer vaccine, which is -70, to lower temperatures, or even the Moderna one? That will be continued. So, but it puts, because of the logistics challenges which have been mentioned, storage at -8, even us in the labs who work in specialized labs, keeping a -70 freezer is not easy. Yeah, they're not easy to keep. They're expensive to run. They break down very easily. Temperatures will fall. So it's not easy. But you can imagine health centers in upcountry health centers in many of our countries, how this will work. Efforts have been made to use solar power and the rest to run fridges. How do you run a -80, -70? It's quite challenging, but it's, of course, for now, better than nothing. You rather look on logistics and save lives, but the lower the temperature a vaccine uses, definitely the better, and more will continue. I think more research and more improvements of these vaccines will continue. RNA, of course, the two vaccines that use very cold temperatures are using RNA. RNA is very delicate. Even in the labs, we use RNA, but it's very delicate. You need to use really cold temperatures. It's a new technology. The first time it's being used this widely in humans. We have to learn more, but definitely storage is going to be a challenge. Thank you.
Thank you, Professor Kalibu. Let's now move on to the next question. It's being asked live by Alex Winning of Reuters. Alex, are you with us?
Yes, I think so. Can you hear me?
Yes, we can. Please go ahead and ask.
Great, thank you very much. So the first question is specifically about South Africa. Could Professor Rees or anyone else please speak specifically to South Africa's cold chain readiness, which may be higher than elsewhere on the continent? Could South Africa handle, for instance, the Pfizer candidate, which has to be stored at around -70? And then the second question is to any of the experts on the panel, which is a question about birth rates. And we've been looking at birth rates, around the world during the pandemic, and we're just interested to hear whether it's possible to identify any early trends in terms of how the pandemic has affected birth rates in Africa. If anyone has done any research on that or has any insights, we'd be grateful to hear them. Thank you.
Thank you so much. So let me start with you, Professor Rees. Dr. Moeti, if you would like to weigh in on that, please do, Dr. Mihigo. Anybody else who wants to talk about the birth rate, if there's been any studies done on any impact or trends that we've seen, as Alex said. So Dr. Moeti, let me start with you, or Professor Rees, and then I'll come to you, Dr. Moeti.
Thank you. So I'll look at the South African question, and could we manage the requirements of the Pfizer vaccine as they currently are? And as we heard, they are actually working on some changes that would allow a much more stable vaccine at different temperatures. So the answer is, and we have looked at this, is that the kind of requirement that you need would be, for example, in central academic teaching hospitals, where many of the ICUs are also concentrated. But beyond that, really not. Now, we could argue that actually that wouldn't be a bad idea, because that would give us some of the sort of highly exposed, this is where some of our sickest patients are, etc. And we could immunize the healthcare workers. But hand in hand with that, you also have to then say, is that your highest risk healthcare worker? Because actually your healthcare workers now in sort of ICUs and in high risk centers, high risk and the most technologically advanced centers, they're tending to have access to the PPE that's required. The people that are not, once we get out, for example, in the Eastern Cape, where we have a major outbreak and a major surge at the moment, in many of the district hospitals there, PPE is inadequate and protection is inadequate. So the irony is that actually you might be having better protected people in those centers where you could store some vaccine, but you probably would need it in terms of healthcare workers, possibly to different categories. So very limited would be the answer. And certainly we working obviously with our EPI program, our cold chain in the ordinary EPI program wouldn't be able to manage that.
Thank you, Professor Rees. Dr.
Okay, so that interesting question about birth rate trends. I think right now what I can say is that no, we're not aware of, and perhaps I can get my team who work on this to pull out what we have available as trend on trends on birth rates. What we do know is that as a result of the lockdowns, pretty quickly, access to family planning, for example, in some countries went down very significantly. So when was halved, or even the gap was even more than that in some of the countries where we did manage to get some information coming back. And then also rather concerningly, access to antenatal services and even having a delivery carried out by a skilled birth attendant also went down. I mean, in general, this was part of the impact of the COVID-19 measures on essential services. I would think that we will start to see, so we are now, the first cases in Africa really started around March. So in the next few months is when we might start to see if there are shifts based on similar patterns from previous years. So I'm sure we'll be finding out soon in the next few months if there has been a change or not. But this is something that we can look up and we can get back in touch with you from colleagues who are dealing with this specifically.
Thank you, Dr. I think Professor Kalibu, you had wanted to say something.
Oh, no,
right.
I think.
I could add a word.
Yes, go ahead, Professor Ware.
Yes, we may not have the precise data on the actual major changes on the birth cost we expect, but we know from Kenya, for instance, that we have had a big rise in teenage pregnancies following the lockdown of schools and the people being at home. That fact, I think, is reported from really throughout the country. So though we cannot give you the exact magnitude of change, it's clear that among the populations that were not expected to be getting into the maternal side of things, we're going to have more in beginning now, because we started the lockdown around about April. So we are counting our numbers. Every region has been reporting that when children were at home, there was an increased rate of young person pregnancy, quite often from non-planned means and within child abuse or sexual abuse. But we expect a higher number of babies, yes.
Right. So before I go to the next question, Professor Rees, did you want to jump in?
Yes, I mean, the answer is, I agree totally with what's been said, we don't know, but to complement what Fred said about behavior under a lockdown, I mean, one of the other things to think about is for those people using contraception, what technologies were they using? And in quite a lot of countries, the predominant contraceptive being used is an injectable progestin. And they have an effect on the woman's body, which means it takes quite a long time, a number of months, to return to fertility, just under ordinary circumstances, unlike those who would be on the pill, where you miss a few pills and fertility comes very quickly. So it's also going to be influenced at a country level for those using contraceptives, if they couldn't access, by which technology they were using.
Thank you so much, Professor Rees. So I've got a question here from Pamela Amunazo from BBC Africa. So it is in French. If I could please get the response from Dr. Moeti in French, and perhaps Dr. Mihigo, if you'd also like to weigh in on that. So the question is about the DRC country, that there's talk of a second wave of contamination. What is the WHO planning with regards to helping the country, especially since the first wave had seriously affected the economy? And is WHO planning to do mass testing in countries like the DRC? Testing has not been done until now in order to know that the real number of people affected. Dr. Moeti?
Oui, merci. Merci pour cette question. Bon, effectivement, ce que nous voyons en RDC, c'est que le virus circule principalement à Kinshasa. Bon, il y a aussi des cas au nord Kivu et dans quelques autres provinces, mais la plupart des cas confirmés sont à Kinshasa. C'est vrai que vers septembre, ils ont reporté peut-être 12 cas par jour. Et en fait, notons que c'est un pays qui est très peuplé, donc le nombre de cas, nous notons le nombre de cas par population est assez bas. Ça restait toujours bas. Et au début, il y avait beaucoup de cas, c'était principalement à Kinshasa aussi. Donc, il y avait la transmission au niveau communautaire à Kinshasa. Ça s'est arrivé à peut-être 100, 200 cas par jour. Mais depuis le mois je peux dire quoi, maintenant, nous sommes arrivés à avoir 55, 45 cas par jour. Donc, c'est vrai que par rapport à ce qui s'est passé peut-être il y a 2 mois, nous voyons un nombre un peu plus élevé de cas. C'est principalement, comme j'avais dit, dans la ville de Kinshasa. La stratégie de dépistage en RDC a été toujours plutôt sur les malades qui manifestent la maladie. Donc, c'était un peu concentré là-dessous à Kinshasa. Il y a des plans au niveau du gouvernement de faire maintenant quelques enquêtes avec le kit de dépistage rapide. Ça peut permettre de savoir là où le virus est en train de circuler. Donc, je peux dire que par rapport à ce qui s'est passé il y a 3 mois, 2 mois et quelques, le nombre de cas quotidiens est élevé, mais nous trouvons que pour un pays avec la population de Kinshasa, ça ne peut pas être considéré comme une crise. Sûr que nous devons, comme on dit, continuer à faire ce qu'il faut faire, améliorer le dépistage, et puis aussi le suivi de contact et l'isolation de ces personnes-là et l'utilisation de masques. Là, je crois qu'il y a beaucoup d'efforts à faire pour rappeler à la population que même si le nombre de cas n'est pas trop nombreux, il faut mettre en œuvre ces gestes barrières qui sont très, très importants. Merci.
Thank you, Dr. Moeti. I'm going to ask if my colleague, Paul Adepo from Lancet and Devix is online. I believe you want to ask your question live. Paul, do we have you on? Paul?
Yes, I'm here. Can you hear me?
Yes, now we can. Please go ahead.
Yeah, thank you very much. So I have a question for Professor Rees. As an expert, considering the major stumbling blocks before the deployment of these vaccines, do you still think, looking at how Africa has gone in controlling the pandemic without the vaccine, what is the justification for still going ahead and investing heavily in procuring these vaccines that would only in the short term benefit a few proportion? I think Dr. Moeti said just 3% of the population. So for Dr. Moeti, I want to have an update on the rollout of RDTs for COVID-19 testing, which you mentioned a couple of weeks ago. And what is the current status? And how do you think Africa's can actually rapidly have access to the COVID-19 vaccine? So thank you very much.
Thank you, Paul. Cerise?
Yes, and it's a question that we've actually discussed within the region. So it does appear that the nature of how the virus has behaved in the African region doesn't seem to be as it has behaved in Europe. Now, having said that, in South Africa, we're having a second wave in one of our poorest rural provinces. That's very significant and is approaching what the scale of the first wave. The second thing is that one of the arguments that's being put forward is, do we need a vaccine because so many people might have been affected, but asymptomatically they'll have antibodies. We've seen reports of levels of antibodies indicating past infection in 40%, 50% from, sort of isolated serosurveys. But the answer to that is we have no idea what we will really need to have what's called herd immunity. So probably the estimate at the moment, and it's varied from the time the pandemic started from as low as 10% up to 80%. But the estimate that you'll see from modeling is probably between 50 and probably as much as 70% if we were to have herd immunity. And that's either from natural infection or from a vaccine. So we can't say with any certainty at all that because we might have had a high force of infection, particularly say in dense urban settings in our region, that's going to mean that we're going to have very minor second waves. The second thing is the majority of people in many countries have still not been exposed to this virus. So what we're saying, and if you put the figures of how many people there are in the region, over 1 billion people in our region, you put those figures together and you say over time, pretty much everybody is likely, with some exceptions, the majority of the populations, if you do nothing, will be exposed to this virus, particularly if fatigue sets in and all the measures that we're encouraging people to use are not used. So if they're all exposed, even if you say, well, it's 20% that gets sick, it's 5% who need hospitalization, and in our settings, it's sort of perhaps 2% or less than that die, that's an awful lot of people. And the economic disruption and the social disruption and the ongoing lockdown, lockup is going to cause havoc. So you have to weigh that and what we would have to do to contain a second wave. We're talking in South Africa at the moment about should we be doing more lockdown measures in the Eastern Cape and the Western Cape? What do we do to respond to this? If we keep doing this, the economies of our countries are really, really going to suffer. But the experts who are looking at this with all of those levels of uncertainty, despite the fact that I agree with you that it looks like we've had a different kind of epidemic in many of our countries, the vast majority of people are saying we definitely will need vaccines. Without that, we are going to go on seeing this massive disruption to our community.
Thank you, Professor Rees. And I wanted to mention earlier on that Johannesburg Hadidars always want to announce themselves. So I see you've got company there. Dr. Moeti?
Okay, yes, thanks very much. I mean, if one can add anything to Helen's excellent response, is to say in most African countries, the vaccine is circulating, when it is circulating, mainly in urban areas, in the capital cities, and in the kind of centers of the economy. So as long as that is the case, even if we can say, well, a few elderly people can die because they had pre-existing conditions, which is also tragic if we multiply them in the countries. It is in the places where the economic activity is most vital in the countries that the virus is circulating. This just increases the risk, and our belief is that if there's a solution that can enable normal life to resume and the horrendous economic impact that is going to be with us for some time to start to be addressed, then we should absolutely take it on. The rollout of RDTs, as I indicated, WHO working with partners has been able to secure some significant supplies of rapid diagnostic tests, and WHO has also agreed to the emergency use licensing of a couple of reasonably well-performing rapid diagnostic tests. We see that increasingly countries are interested in using these, especially for cross-border testing of people who are traveling. And then we encouraged, as we said the last time, that they be very much used to confirm cases, confirm where the virus is circulating, to be able to get a better handle of the pattern of transmission, so that it can be possible to do the kind of thing that will enable the lockdown easing to continue, meaning to focus on local action where we see the virus is circulating among cases and contacts to contain the spread. I'm not able to give more precise figures of how many of the targeted number of distribution we have managed to carry out in WHO, but I know that we are working very much with our colleagues in headquarters and other partners on the distribution of these RDTs, and we'll be able to provide you, if we take note of who asked this question, with the information again from our team, which is not connected on this call because we mainly were expecting to be talking about vaccines, but this information will certainly be available with our logistics team in our incident management group. We can send it to you.
Thank you, Dr. Moeti. So we've got a question here from AFP, and I want to find out, Sophia Christensen, are you in a position to ask your question live? As in, would you like to do that? Sophia? Okay, if you do want to pipe up, I'll read your question so long. So it is directed to Dr. Moeti. It's about something that you mentioned earlier on, Dr. Moeti, this criteria. She's asking that you please elaborate a little bit more on the WHO criteria for vaccine readiness. The fact that you spoke about 80% ready when it's below a country threshold, what exactly does that mean?
Okay, thanks very much for that question. So I'll suggest that Richard provides the details of this aspect of the preparedness.
Okay, thank you, Dr. Moeti. Usually in any vaccination drive, there are a certain number of parameters that country puts in place and follow up to make sure that all the different pieces are together to have a successful vaccination campaign or introduction for any new product. So for this particular COVID-19 vaccine delivery, WHO working with partners, particularly UNICEF, we've came up with a number of criteria and parameters, 10 in total, that is going to measure the level of preparedness of the country vis-a-vis the rollout of the vaccine. So these parameters range from planning and coordination aspect, regulatory readiness to make sure that the vaccine can be registered easily, supply chain, logistics and cold chain, communication, risk communication, community engagement, safety monitoring, etc. So all of these different parameters are followed up and can be scored in terms of readiness or not. So after looking at all of these different parameters, an experience has shown that when we have an average or weighted score around 80% or above, clear